Okay, yes. Thank you. At this time, I would like to introduce our wonderful, hardworking transport scholars, Dr. Camacho Rivera included. So, Dr. Camacho Rivera was a transport scholar and a postdoctoral fellow program graduate of the transport program. She is also the assistant dean for student engagement and success, as well as the assistant professor of community health sciences in the School of Public Health at Downstate. Thank you.
Thanks, Lakia. Such a pleasure to be able to transition into the next phase of our presentations. I think it's a great transition when we're talking about the previous panel with respect to sustainability, and there were themes around mentorship and being able to build capacity. We've been talking a lot about community as if community is outside of these walls, and so it's really great to focus this next phase of the symposium on the community within these walls. And part of what Transport, as well as some of our other training programs through the Clinical Research Scholars Program funded by NIMHD, as well as our HRSA Center of Excellence Fellows, which you're going to be hearing from within our oral presentations as well as our poster presentations, is really working on the structural barrier of strengthening our capacity to be able to do this research by diversifying the scientific workforce that's doing community engaged science and health equity research. And so you're going to hear from scholars who not just represent diverse backgrounds with respect to their lived experiences, but with respect to their educational backgrounds, clinical training, as well as the content areas that they're focusing on. And so I think I'm gonna stop there, but you'll learn a lot by being in community with and learning from our incredible scholars who have been doing this phenomenal work over these last few years. And so I'm going to allow, where is he? Dr. Kutsia Banu, who is going to give our first presentation for today. Thank you.
Thank you, Dr. Camacho Rivera, for the kind words and introduction. So my topic is evaluation of glycemic control in patients with uncontrolled type 2 diabetes with continuous glucose monitoring technology in a health disparate community. My name is Kutsia Banu, and I'm an internist, as I said before, and I work in East New York with a very diverse community. And my institution is One Brooklyn Health. So the study objective and purpose was to compare the outcomes of patients with uncontrolled type 2 diabetes who have used continuous glucose monitoring to titrate their treatment regimens versus non-CGM-based care, patients who had non-CGM-based care. So continuous glucose monitoring, for short called CGM, is part of what we call advanced diabetes technology. So basically, it constitutes a sensor which is placed just under the skin to record glucose levels, and a wireless transmitter sends readings directly to a reader, or it can be a patient's smartphone or app, no spatial reader especially required. The CGM system takes glucose measurements at regular intervals, and it can be as frequent as 1 to 5 minutes. So we are all aware of patients taking their finger sticks to see what their glucose levels are at that moment. So compared to that you can scan every 1 to 5 minutes, is painless, and this can be used to provide immediate feedback on treatment, especially insulin injections. And it can also inform the user of significant hypo and hyperglycemia with an alarm. So thinking about this, theoretically, this should create a more optimal regimen with improved treatment and safety outcomes. Just a quick slide to show the sensor and the reader and how the readings can be graphed to have a visual representation, and the top their actual numbers and percentages that the patient and their care team can use. So what's the significance of this? Type 2 diabetes mellitus is one of the most prevalent chronic diseases in the United States, About 37 million Americans live with diabetes, and the overwhelming majority of them have type 2 diabetes. Despite current advancements in diabetic treatment, the national burden of uncontrolled diabetes and its complications remain high, with American Indian, Black, and Hispanic population disproportionately affected. Uncontrolled diabetes can lead to serious micro and macrovascular complications. So this would be heart disease, stroke, neuropathy, nephropathy, retinopathy, eye disease, and peripheral vascular disease. So advanced diabetes technology, our hopes are that it can play a significant role in improving diabetes care, but so far few studies have looked at the role of CGM in controlling type 2 diabetes, and more research is needed to generate evidence on the utility of CGM in this population. So a lack of robust outcome data means that there is no proof of cost effectiveness or less proof of cost effectiveness. This has caused Medicaid in many states to not cover CGM for type 2 diabetes for people who need them, contributing to health inequity in terms of resources to underserved and minority population. In that context, our first specific aim is to assess the role of CGM in improving hemoglobin A1C, which is a marker of diabetes control, in patients with uncontrolled type 2 diabetes in the setting of provider-driven CGM data review and patient counseling in our diabetes medication management clinic. Our second specific aim is to examine whether patients using CGM had fewer hospitalizations and emergency department visits than patients who did not use CGM. The underlying thought behind that is while CGM is more expensive, if they avoid hospitalizations and emergency visits, then they more than pay for themselves. Design and methods. This is a retrospective study to assess the feasibility of future planned investigations. The participants are adults with a diagnosis of type 2 diabetes and uncontrolled diabetes defined by a hemoglobin A1C of more than 9. The setting is Brookdale Hospital's diabetes medication management clinic, which is located in a CMS-designated low-income and health professional shortage area. The look-back period is January 2022 to February 2023. The method is propensity matching of CGM titrated care group and non-CGM care group. There was no acute interventions, and the observation period was at least 3 months from the baseline visit, the baseline visit being when the first CGM sensor was implanted, and the primary outcome was hemoglobin A1C at 3 months. So a quick recap, they were adults with type 2 diabetes, uncontrolled diabetes with an A1C more than 9, and they were enrolled in the year of January 2022 to February 2023, and patients were excluded if they had a different kind of diabetes, refused to use CGM, or did not have a follow-up hemoglobin A1C after at least 3 months. The procedure, all eligible patients were offered CGM devices and explained that the use was voluntary. Those who agreed to use it received the data review and targeted counseling, as well as the diet, exercise, and medication management counseling that we do. The data was reviewed with patients in the office or through telemedicine platforms at their scheduled visits, and this data was used to titrate medication and provide counseling. All patients who refused CGM still received intensive diet, exercise, and medication management counseling. They were advised to check their blood glucose via finger sticks at least once a day. A standardized template for glucose monitoring was used in either case. Abbott Freestyle Libre was used for CGM, for standardization of counseling techniques, and hemoglobin A1C was done by whole blood using immunoassay at LabCorp Clinical Lab via Brookdale Central Laboratories. All data was collected retrospectively from the EMR with convenience sampling, and our parameters, which are routinely collected at One Brooklyn Health. Abstractors were pharmacy residents, and data was recorded via a standardized abstraction instrument. A total of 21 patients were found to be eligible for inclusion in the CGM cohort. So here we have our data. So you can see the total number was 21. 52.38% male, 47.62% female, so fairly close. The average age was 55. 85% were Black, 14% were Hispanic. The patients were somewhat overweight, with the mean weight being 89 kgs. Their baseline A1C, a marker for diabetes control, was 11.46, which shows that they were quite uncontrolled. 85% of them used insulin. For the CGM, and they had a mean number of visits, 3 visits to titrate with CGM data. We also looked at prior authorization, because that's one of the barriers in obtaining CGM technology for everybody. So 1/3 of the people had no delay in obtaining CGM from their insurances, but the average days in prior authorization varied wildly, with the mean being 24 days, but you can see there was a very large standard deviation. So once the patient used CGM for 3 months at least, there was a repeat hemoglobin A1C done, and the mean change of hemoglobin A1C was an improvement of 2%. So to put that into context, 0.5% of hemoglobin A1C change is considered clinically significant. And then the other aim, we collected hospitalization data. There were 10-year visits which happened between 4 participants with no hospitalizations. Out of the 10 visits, only 1 was directly due to either hypo or hyperglycemia. 25% of the total enrolled were excluded due to a subsequent refusal to use CGM or non-compliance with eligibility criteria. So currently, we are collecting data on the larger subset of patients who did not use CGM in the designated time period. So once we have that, we're going to match patients who used the CGM to patients who did not use CGM on baseline characteristics, trying to make the cohorts as equal as possible using propensity scoring, and compare their 3-month A1C post-matching via regression model. Patients' demographics will be summarized using descriptive statistics and compared using a 2-sample t-test, the Pearson chi-square test, and non-parametric testing. Our primary outcome of interest, hemoglobin A1C as a percentage, will be analyzed using the mixed effect model and ANCOVA to account for repeated measurements of participants and autocorrelation. This outcome will be measured at 2 points. Count data such as hospitalizations and ER visits will be analyzed using Poisson's regression or negative binomial regression. P-values less than 0.05 will be considered significant, and all analysis will be done in SAS 9.4. So limitations, this is a retrospective study, and the sample size were relatively small. This kind of reflects the problems we had of creating a community-based CGM clinic, standardizing it, and also getting prior authorizations. On the flip side, this is very sustainable. This is a standard clinic now. It's still going to go on when the project is finished. The fidelity is high because this is a structured course that we use for residents in medication management clinic. COVID-19 pandemic did limit our recruitment and execution of the CGM program and associated education intervention. A shout out to our current team, and thank you very much.
So at this time, I would like to introduce Dr. Rose Calixte. Did I pronounce that right? Calix. Dr. Rose Calix, who is the Assistant Professor of Biostatistics in the School of Public Health here at SUNY Downstate Health Sciences University.
Thank you. Hi, everyone. Today I'm going to talk to you a little bit about the research project that I have been working on as part of my transport fellowship. So the title of my talk is Sociodemographic Correlates of Unmet Medical Needs in Children with Developmental Disorders. This is an analysis of the National Survey of Children Health, and I use the 2016 version of the survey. So to give you a little bit of background about children in the United States. So about 14 million children in the US have special health care needs. And of those children, 12.8 million of them have developmental disorders. And developmental disorders are lifelong conditions. And because they are lifelong conditions, they require a lot of significant health care at home. And this comes at a very substantial cost to family, and sometimes it leads to high level of poverty within that population. And prior studies have shown that children with special health care needs have high unmet medical needs, and this is when comparing them to typically developing children. And if we are thinking about the definition for unmet medical needs, we can think of it as services that people perceive as needed versus the actual services that they receive. And in terms of looking at healthcare services for children with special conditions, the Maternal and Child Health Bureau defines certain characteristics of what they consider to be adequate care. And looking at children with special healthcare needs, only 15% of them in the United States are actually receiving adequate care. And because of that, parents spend a significant amount of time with care coordination and other aspects of their care and leaving them, and it actually, burdensome, and it's really additional in terms of time and money. It is very costly. So the goal of my study was to really looking at the population of children in the United States with with developmental disorders and look at the characteristics that are associated with unmet medical needs. So we did a cross-sectional study looking at children with developmental disorders 0 to 17 years old from the 2016 National Survey of Children Health, and we identified children with developmental disorders using the following questions. And so the parents, they survey parents and ask them specific questions about their kids. And some of the questions had to do with developmental delay, intellectual disabilities, speech disorders, and autism, and ADHD or ADD. And for the outcome, we look at two questions that parents were subsequently asked. The first question was, thinking about the past 12 months, they asked them, was there any time where their kids needed any type of health services and they did not receive it? And thinking about health services is not just medical care. We can think of it about in terms of therapy and any other thing that those kids need to fully function in society. And they were asked a subsequent question to think about the reason why they did not receive the care and to mention whether or not it was due to cost. And for our analytical approach, because this is a complex survey data where they actually had to do a multi-stage sampling in the United States, and so they did stratified sampling, and so because of that, we had to incorporate all that in the analysis to make sure that the results were representative of all children in the United States with developmental disorders. And we did some univariate and multivariable logistic regression so that we can look at factors that are associated with our outcome. So looking at the analytic sample, for the 2016 survey, they surveyed a total of 50,212 children, and of those, 9,073 actually were kids with developmental disorders. And that represents about 17% of all US children. And of those children with developmental disorders, I keep forgetting the youth because this is 0 to 17, so it's not just children, it's children and youth. Of all these children and youth with developmental disorders, 6.8% reported that they did not receive needed care in the past 12 months, and about 4% were due to cost. So looking at some of the descriptive of the population, so I highlighted some of the interesting facts in the data. The first thing that caught my attention was the proportion, the sex distribution in children and youth with developmental disorders. About 65% of them are male. And the second thing I want to highlight is that 16.4% are Black. Number 3, 21.5% are Hispanic. And so we can see that the proportion in both the Black and the Hispanic community is much higher than their actual representation in the US population. The fourth thing I want to bring your attention to is the fact that in the United States, 1 in 6 children live below the poverty level. When we look at children with developmental condition, it's 1 in 4. And so kids with developmental conditions are more likely to live in poverty. Interesting fact is that within that population, we have near universal access to health insurance. 96.4% of them have health insurance. So looking at our univariate analysis, so within the not receiving care, we see that Black children were more likely to report that they did not receive the care that they need in the past 12 months. And the second thing that I want to point your attention to is that those living below 300% of the federal poverty level were more likely to not receive needed care. Looking at our multivariable results, if you look back in the previous slide, I'm not going back. On the not receiving care due to cost, we didn't see anything that were major. But when we look at the multivariable model, we see that Hispanics were more likely to not receive needed care due to cost. And on the other side, which is the not receive needed care, we see that those living below the 300% federal poverty level were still more likely to not receive the needed health care. And that is very interesting because we saw 96% of those children actually have access to health insurance. And that really is thinking about, not all health insurance plans are equal. And so thinking about the care that kids need is that, some may not be covered. And also we have to think about copay. So if the parents cannot afford the copay, it doesn't matter if you have health insurance, because if you cannot afford the copay, then you are not going to go. And so really what I want to point your attention to is the fact that children and youth with developmental disorders from households with 300% below the federal poverty level were at higher risk of not receiving needed care. Hispanics were also at higher risk of not receiving needed care due to cost. And while only about 7% of all these kids reported not receiving needed care, and only 4% of them did not receive it due to care, we can still see that there are some disparities there, looking at income level and race, Hispanic or ethnicity. We can see that there are things that we need to address. And this is where the work that I am trying to do, I think, is going to make a difference, because what I want to do is develop a screening tool so that we can implement it at the point of care where clinicians and care coordinators can actually identify those kids that are more at risk of unmet medical needs, so that we can direct them to community services and really bring those resources at the point of care so that those kids can access the care that they need. So these are some of my references, and I would like to highlight my mentoring team, Dr. Camacho Rivera, and the chair of my department, Dr. Elsner. Thank you.
So at this time, I would like to introduce our next scholar, Dr. Melissa Lee. She's the clinical assistant professor at SUNY Downstate and Kings County in internal medicine. Thank you.
Thank you so much. Is this the, can go here? Okay, I'm going to come in front because I'm going to be behind the screen because I'm not very tall. It is so exciting to be here, and I just want to thank you guys for inviting me and giving me opportunity to be in the CREST program to really come up with the language that I think I can use in a positive way to kind of take primary care to the next level. So my name is Melissa Lee. I'm trained as an internist pediatrician, and I do primary care at Kings County, and I'm also the program director for our new primary care internal medicine residency program. Thanks to Dr. Salafu, we have our final class that's joining us this summer. So I'm going to walk you through a program that we did last summer, the seated exercise for older adults. So a shout out to some research being done for folks who are over 65. Okay, you guys know where I work, across the street at King's. I'll tell you, we have, for older adults in our primary care practice, we have about between 13,000 and 14,000 patients, and most of them are underserved, as you know. So why was I particularly interested in this? Well, because my patients, I don't know, does anybody have a Garmin on right now? Any watch? As I'm sitting here, I'm getting this thing that says move. Do you ever get a buzz that tells you to get up and move? Yes, okay, so I got that. So we're gonna do a little bit of that right now because I think you guys have been sitting for a while. So we first went to our patients and we asked some of our older adults, it was small, it was just about 21 people, just what kind of physical activity they were most interested in learning about. So what are some favorites physical activities? Has anybody exercised today yet, or yesterday? Stretch, okay, what else? Walking, that was one of the most popular forms of activity for our patients. Any others? Martial arts, that's awesome. We didn't have anybody tell us that they did martial arts. Okay, so what were our, oh, you got one. Resistance bands, I love it. You read the title of my talk here. I plan to do, okay. So what our patients were most interested in doing were stretching, strengthening, and balance, and it wasn't cardio, which is kind of the thing that I always think about when I exercise. So, you know, proof of the pudding, ask your patients what they're interested in before you try to develop a program. So all of our patients felt that physical activity was really important to their health. Most of them exercised alone, and a lot of them did walking. Interestingly, many patients, I think 50% had never used a resistance band before, but 90% of people wanted to learn how. And so we started looking at how we could make this work in our community. So this is some background information. This was a study of about 4,000 people, and the intervention was an exercise prescription that was given during a primary care visit. And when they did this, you know, it was we're going to sit down, we're going to set some goals. What would you like to do? Interested in exercise? Yes, you know, this would be a good thing to go forward with. Let's set some SMART goals. And so people who got advice only, this is for all ages, they increased their activity by about 18 minutes, so per week. So it's not bad, right? I mean, if somebody's going to exercise 20 minutes a couple times a week, then an extra 18 isn't bad. But look at what happened to people who got advice and also got a specific individualized prescription for exercise. They actually increased their exercise by over 2 hours a week. Is there anything that anyone's ever told you that helped you exercise 2 hours more than you did the prior week? I mean, that's a lot. Like, that's a lot of time. And so it also doubled the intensity of exercise, and I think that's something to think about as well. So we're trying to figure out what could work for our patients. Other studies were big, like so they had 800 patients. The Life Peace study is often pointed to in the literature. Mostly white patients, mostly women, mostly folks who are college educated. So this didn't really fit my population of patients who I care for at Kings County. This is a very small study, 16 older inner-city African-American women who did resistance band and dumbbell training for 3 days a week for 4 weeks. And look, there's an increase in lower body strength and an increased upper body strength. So they measured this using a 30-second chair stand. Has anybody done this before? I know that I made Dr. Lambert do this last week. So has anybody ever done a sit to stand? Okay, so this is a little risky, but like if you promise to make your chairs stable, I'm gonna show you how. Okay, so you're gonna sit down and get your feet solid on the ground. You're gonna cross your arms across your chest, and you're gonna stand up. Come on, we've been sitting all morning. Let's try this. All right, and now we're gonna sit down. And now we're gonna stand up. And sit down. Come on, Dr. Salifu. All right, we got Dr. Salifu doing it too. Excellent. So I won't make you do the whole 30 seconds, but that's what it is. And so basically you check for 30 seconds to see how many times somebody can do this. And it's a measure of their lower body strength and really their risk for falling. So that's one of the things we do to check for fall risk in our patients. Okay, so this, if we could do something like this, it was low cost, it was accessible, and also we felt it could be sustainable. So what were our objectives? We really were looking at older adults, and we wanted to engage them in a home-based seated exercise prescription intervention. We wanted to use motivational interviewing because this is what we do all the time in primary care, so why not use the tools you have and apply them to this research? And then we wanted to see the impact. So these were our patients. Most of them fell between the ages of 65 and 80. We had a couple of older adults, mostly women, so 78% women, 100% identified as Black or African American in EPIC. And in terms of insurance, this is what I was a little bit surprised about. This isn't exactly the mix at Kings County. So we have a lot more patients who had fallen to the uninsured. With New York City Cares, that is a form of insurance that we're categorizing, but most patients had Medicaid, Medicare, or both. So what did we do? We screened them for fall risk. So we did the sit to stand, which you can see over on the far right. We also did something called a timed up and go. So somebody would sit in a chair, you walk 10 meters, you walk back, and if you can do that in 12 seconds or less, you have a lower risk of falling. We also did a memory impairment screen, so that's the PMIS I've shown you there, and that's because if you're going to give somebody an exercise program, you want to make sure that they can remember to do it. And then did the Falls Efficacy Scale International, which is a number of questions about fear of falling. We created a video, and we've found that when we do homegrown videos with our own staff, they're most effective. So I begged my team at the diabetes education program to participate. And so you see a couple of our exercise coaches from our gym and some of our nursing staff and one of my awesome residents who filmed this. I won't tell you who narrated it. Lots of classes at the Y trained me for that. And then we had some medical students from CUNY who created this program with large print and pictures. So after the CP referral, we did the assessments and then we taught them the program. We called patients over the course of 2 months, every couple weeks. They got like 2 to 3 phone calls and set SMART goals and tried to find out what barriers there were and what their motivation was to continue. And this is what we found. So that 30-second sit to stand that you guys just did, that was the one thing that we did find improved. And so thanks to Rose, who was my biostats teacher, I now understand the statistical analysis. This is very exciting. This is why to do the MPH, right? And so the other test actually didn't have a difference in terms of fear of falling or their timed up and go. We couldn't compare it because the final group was these were all phone calls. And there was no change in terms of vigorous or moderate physical activity. So what are we going to do next? We're going to look at this pilot data and kind of take it to the next step to be determined this summer. We're going to apply a theoretical framework, so that's from my next class that I'm taking, to try to guide our steps and really want to spread this, because if this works, then how do we make it work for more patients in our population? And really identify people who are ready to change and ready to engage in this and try to optimize it within the workflows we have in primary care. Thank you.
Thank you, Dr. Lee. I enjoyed the exercise portion. So at this time, we're going to have Dr. Jose Diaz present, but he's going to present virtually. Dr. Jose Diaz is a research scientist in the STAR program here at SUNY Downstate Health Sciences University, and he's also a fellow in the Research Education Institute for Diverse Scholars program at Yale.
Hi, everyone. Sorry that I'm not there in person with you. I'm part of the chorus of folks who are not feeling super well at the moment. But I'm going to talk to you today about a pilot study that I conducted as a part of a larger research study with Dr. Sabina Hirschfield and our colleagues at the University of Miami and San Diego State University. And it's specifically talking about the home collection of blood specimens for HIV viral load testing among sexually minoritized men who use stimulants, particularly methamphetamine. And because I'll be talking about a couple of devices, I want to say that I have no conflict of interest or financial disclosures related to these devices. These are just my personal opinions and I guess professional opinions too. If you take nothing else away from today's talk, the little seed that I would like to plant in your mind is that methamphetamine use is a renewing epidemic. It's been surging over the last handful of years, maybe a little bit more than a decade at this point. And it's sort of starting to supplant and take place of the opioid epidemic, or really exist alongside the opioid epidemic. And it's not necessarily something that we can silo off into substance use treatment. Stimulant use is associated with things like disengagement from HIV care and lower levels of viral suppression, and even sort of lack of durable viral suppression. So we may achieve viral suppression among folks who use methamphetamine or other stimulants, but they're more likely to revert back to having unsuppressed viral loads and be more likely to effectively transmit HIV to partners. It's also associated with things like cardiovascular disease, and including methamphetamine-associated cardiomyopathy, which is something that has received some attention in recent years among stimulant-using populations. So if you take nothing else away, if you want to take a little bit of a nap for the rest of the talk, that's the thing that I think is most centrally important. Is that we should do our best to pay attention to this in other elements of primary care, HIV care, and even in cardiology and other aspects of healthcare. But that's not the purpose of today's talk. That's just a little piece of information. The purpose of today's talk is to really talk about adapting HIV care to this modern substance use epidemic, particularly stimulant use. And so the at-home collection of blood specimens for viral load testing has actually been shown to be pretty feasible and acceptable among a variety of populations, particularly sexually minoritized men, including men who use stimulants. There's one study that was conducted by Dr. Hirschfield that showed that the likelihood of returning these kits was no different between men who reported recent stimulant use, including methamphetamine or cocaine, and those who reported no substance use, which might be an indicator that this is a population that can be reached by using devices like these that they collect their specimens at home. One of the things that are really important about this area of giving folks things to collect their blood specimens to send back into a lab for testing is that the technology is still in progress. A lot of the tech uses finger prick approaches, sort of similar to blood glucose measures, but the lancets are quite a bit more painful and quite a bit larger. So you encounter a lot of apprehension for using these kits, including among men who inject drugs. I've had conversations with participants for this study who said that they have no problem, using other needles or syringes, but for some reason that lancet caused them that extra level of stress. So I sort of jokingly say they kind of hate this approach. And one of the things we wanted to study as a part of the study is whether an alternative device might be more user-friendly and more appreciated by the population. And so what we did is we compared the use of the HemoSpot HD kit, which is this little purple device, which isn't going to show up because of my magic background, versus the Tasso M20, which is this more newfangled device that you can put on your upper arm. And just as a quick description of the two, the HemoSpot is one of those finger lancet kits, and it's relatively inexpensive, he says, sort of cheekily, noting that we've been talking about issues with funding and accessing funding for folks. But compared to the Tasso, it is a lot more affordable. Whereas the Tasso kit is sort of trades affordability for reducing the anxiety that potential folks who may be using that kit will face. So it's a device that you just essentially take and you put on your shoulder, you press it in, and it collects the blood sample for you, which is a really great tech idea. But unfortunately, that cost of $40 per kit or $25 for research purposes is a little, let's say, steep. For inclusion in this study, we focused on cisgender men who have sex with other men who are living with HIV. They also reported suboptimal ART adherence, meaning that they were not taking their medications. They were taking their medications less than 90% in the past month. They reported that themselves. And they also scored as having moderate to severe stimulant use, meaning that we would think of them as being, sort of conversationally as having an addiction to methamphetamine or cocaine. And that was using one of the validated measures for assessing stimulant use disorders. Some brief sample characteristics. It is a relatively small sample of 24 individuals. The median age of folks was 47. So we sort of sit in the middle of younger folks and folks who are, as we were talking about earlier, folks who are a little bit older. So we were able to reach some folks of a variety of ages. And importantly, if you look at that assist or the methamphetamine score, what we're showing here is that we had a pretty high median score of methamphetamine use disorders. So these are folks who are reporting a lot of frequent cravings and sort of that methamphetamine may be impacting their day-to-day lives. And that was the primary population that we were able to reach with this study, is folks who are very heavily involved in their methamphetamine use. So I put up this picture because I think it's pretty, but I'm not going to talk about it in great detail. But what it shows essentially here is that these dark blue bars are how long it took for each individual participant to get the kit sent to them at the start of the blue bar, and for them to return it to us at the end of the blue bar. And we see, if we just look at those dark blue bars, we see a variety of different time periods. And I'll talk about what that looks like on the next page. But what we also see is that some folks needed us to send that kit back to them a second time because they lost their first kit. And that's in the sort of pink diamond. And in this orange triangle, what we see is that some folks never returned, specifically the Hemaspot kit to us. And I'll tell you why I'm just talking about the Hemaspot kit in just 1 second. Overall, from start to finish, it took an average of 68 days for folks to complete the study. And the study included a survey at the beginning, then us sending the kit to them sending the kit back to us, and then us interviewing them qualitatively to discuss their experiences with using those two kits. But I think what's most centrally important for today's talk is that it took about 23 days for folks to have the kit sent to them on average, and for them to get it back to us. And that includes USPS processing times and university mail processing times at the University of Miami, which we could have a whole conversation about, but it's a long period. So it was actually relatively fast to get those kits back from participants, although there was a maximum number of days of 86. So there was definitely a spread. So that's sort of the process. In terms of the results of the viral load testing, these are from the Hemaspot HD kits. And what we have here is what's called a waffle plot. And essentially the stuff that you see in this box here are folks that shared a sufficient sample of blood for us to be confident in their viral load testing. And among them, so that was about 63%, which was partially our responsibility. We updated our instructions as a result of the first batch of folks who were sending kits with insufficient blood for analysis. But what we see among that 63% is that actually about 77% of them, we were able to quantify or detect their viral load, which means that we were able to identify folks, particularly those in orange, who are at incredibly high risk of HIV transmission. One of these individuals had over 50,000 copies per milliliter of HIV in their blood, which is quite a scary proportion of HIV, meaning they're very unregulated. Whereas we have these folks in purple who have a detectable viral load, but it's not necessarily quite as high. So it's under 832 copies per milliliter. And then we had some insufficient samples, which we can't be confident in the level of HIV in their blood. And those are the folks that we sort of worked to improve our ability to analyze their samples moving forward. So in terms of the summary, this study was really built off of conversations with the Community Advisory Board around, and not only that, but also around our understanding of this sort of DBS technology or dried blood spot technology, and how it isn't necessarily user-friendly or community-friendly, really, and how something like a TASO kit may be able to help bridge that gap, even though it is exorbitantly expensive. And so when we look at the second section here, what we found is that the return of these kits was actually pretty feasible. We had a return rate of 22 TASO kits for 24 participants and 21 Hemaspot kits for 24 participants. So we believe that TASO is a pretty feasible kit to use for research purposes at a bare minimum. But we've encountered an additional barrier of the lab analyses for those viral load tests requires additional validation. In other words, we just don't necessarily have the tech that we can use to analyze the blood samples from these purple kits is not necessarily the same as the tech that we can use to analyze the blood from these TASO kits. And so that's caused us to have quite a few conversations with TASO, including myself, to try to get to carve a path forward to be able to honor these participants and the blood specimens that they provided to us. And it's looking like we're actually going to make headway on that in the next couple of weeks, which is really exciting. And the last piece is that, what we found is that a large portion of these folks are actually disengaged in care or have limited engagement in care. And we were able to get them to send blood specimens back for viral load testing So this may be one way to help adapt HIV care, including in the interim between regular testing, to meet the population where they are. You know, people who use stimulants, particularly methamphetamine, experience a lot of hardships, including financial hardships and sort of social and structural hardships. And this may be one way to help sort of keep them at least marginally engaged in care as they're sort of trying to get reintegrated back into care. But unfortunately, clinical intervention studies are needed. And if anybody's interested in doing those, this would be we could have a wonderful conversation about that. But that's sort of the next step for this type of research. And lastly, I would just like to thank my collaborators, including Dr. Hirschfield at SUNY Downstate and our collaborators across other sites as well. And thank you.
I would like to thank all of the scholars for their wonderful presentations. And at this time, I would like to bring back up Dr. Salafu, who's going to conclude the symposium with his closing remarks.
This was truly, truly remarkable and wonderful. To the scholars, I think your projects are really on target. You're addressing real community problems. And that is the whole spirit of transport, to be able to educate the next generation of researchers who would then take on these challenges and try to do the research to find solutions to the problems. So I'm really very thankful to all of you for having these great projects, and hopefully the more transport scholars were able to graduate from this program, the more people were able to get to engage in the conversation of trying to make sure that we engage the community and solving the problems one at a time. So we are getting to the end of the symposium. I would like to thank my fellow PIs who have done a tremendous job of trying to put this program together. And then the program staff, Pam Straker and Lakia Maxwell, who are responsible for all this organization here. To our keynote speaker, I think everyone remembered what he said. His talk was so vivid. It's not difficult, it's not easy to forget what he said. So we're truly thankful to you for the contributions you've made to science, your contributions to health disparities, your contribution to the community that you serve, and just really transporting your ideas to Downstate was just remarkable and just great. So thank you very much. To all the panelists, you also did remarkable. You raised the various questions, and the speakers were able to respond to your questions, and the scholars who summarized these sessions. To all of you, the speakers, the discussants, and then the scholars who summarized, thank you very much for what you did. And to all of you now who have really, spent your time with us today, this is a conversation for all of us. This is a challenge for everybody. Health disparities is not for one person to resolve. I think somebody said it the best. We have to resolve one at a time. And all of us talking together. The science meets the community, and the community meets the policy, and that is what eventually is going to happen. We can't go back and reconstruct what was done wrong, but we can begin to find solutions to current issues, or solutions to the issues that have been lingering around for a long, long time. Little by little, little drops make mighty oceans, and that is the approach that we're taking. So thanks to all of you for spending time with us. I saw a group of Brooklyn College students came with their mentor, so I was really very impressed with that. This is Brooklyn College students interested in health disparities research. They came with their mentor to the conference. It's just remarkable to see your team come to join us today, so it's very nice. A few announcements. We have a number of posters. You can take a look at the posters. Very interesting. We have lunch to the very end. Thanks to Lakia and Pam for arranging the lunch. And then basically after that, we adjourn, and then you can leave. Right, so once again, thanks to all of you. Next year, please transmit this information. Let everyone know that every year we have a transport symposium, and we are looking at ways to connect better with the community. That is the goal. And how we can have these bi-directional conversations with the community that makes sense. So we're going to be talking about community in all these transport symposia for a very, very long time. So thank you once again.